and as a result has a really huge bladder, and his penis is basically turned black and I'm afraid possibly necrotic. So what we're doing first is a scrotal urethrostomy, and then we're going to do a penile amputation and a cystotomy. It's got numerous urinary bladder calculi, which are going to have to be managed as well. So I'm starting with my urethrostomy because we've got to reestablish urine flow, so that's the most important part of the procedure here. If you haven't already done so, go ahead and subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So I'm making my initial skin incision right over, or right through the scrotum. So where his scrotum used to be, that's where we're making the incision. Can I get a smaller, number 1 Gelpies, please? So I'm just palpating the urethra. And the key here, the scary bit, is that if we get into the abdomen and the bladder is black as well, we're not going to have a lot of options to manage this. So we're getting down to the penis here. And when we do this urethrostomy, we're just going to suture the mucosa of the urethra to the skin. So just waiting for our bigger Gelpies. And it's really handy if you can get a urinary catheter in these first before you start the surgery, but that is, like, we weren't able to do that. Can I please have a 15 blade? So I've got the penis exposed there. Hello, Connecticut. Hello, Egypt. All right, so I'm making an incision right through. Try to open this up a little bit more. Try to keep that straight for me, please. All I need to do is get one little opening into the urethra, and then I can extend it with Metzenbaum scissors. I'm not sure that...
Can we get a suction put in, please?
And again, it's much easier if you can cut down onto a catheter, but we're unable to pass one in this dog. There we go. So we've got an opening now into the urethra. So that's inside the urethra now. So it's good to see that this part of the penis is not black. Did we get a urinary catheter, please?
Yes, I have this one.
That's fine.
It's a temperate.
And what's the end look like? Yeah, can we get a syringe as well, about a 20 ml syringe?
Yeah.
So I can already see some stones. I'll try to pass the catheter down this way first. Okay, so that is in there. That's excellent. So that makes me much happier. So we'll go ahead and drain. Let's get another. That urine is looking pretty gross. You want to make this stoma about 3 centimeters generally.
Is that because it contracts down?
Yeah. So Sarah was just asking if that's because it contracts down, and that's exactly right. I don't think we need that. That's right.
What's the worst that could happen?
What's that?
What's the worst that could happen? Do you want us to read or something?
What?
You square me.
Right.
Yeah, we've got that.
So this is going to be such a big relief for this dog. All right, I'll have you guys keep doing that. Can I get some 4.0 PDS, please? And so what I'm going to do here is just a simple continuous suture pattern from the mucosa to the skin.
How do you get the area sterile to stay for urine on that?
So urine is generally considered to be fairly sterile, but basically you just do your best. But it's not a major concern to have contamination with urine. And we'll have to probably just keep suctioning the stoma as I'm suturing, and just be careful that urinary catheter doesn't come out. Yep. Have you run that, please, for me, Sean? Just run that suture for me. Suction right there. So I have to make sure that I'm actually picking up mucosa.
How many centimeters is the bladder when you finished up, Sean?
I think it's still about 8 or 9.
Suction there so I can make sure that I'm getting mucosa.
That's it.
All right, so we've got the bladder negative.
You can say that's it.
So suturing to the mucocutaneous junction that reduces the risk of a stricture formation.
Yeah.
There's a hole out there. This one? Yeah. Just up here? Oh, okay.
I'm coming to the apex here. And when you're suturing the mucocutaneous junction, it's always easier to suture from the inside to the outside to be accurate with your placement. So learning how to suture backhand, a really good skill to have. And as you're developing as a surgeon, you should practice it at every opportunity. Go ahead and take that out, I think. Look at that, one stone out. Section, please, just to get that blood clot off.
Find a difference between simple continuous and simple interrupted?
There is no difference. Yeah, it's just quicker. There was also a study that was done, like if you were doing this procedure in order to relieve an obstruction because of stones that were in the os penis, you can either suture it closed or leave it open. And when you suture it closed, the benefit of suturing it closed is that you just reduce the bleeding. It doesn't have any effect on stricture formation or anything like that.
And when you say suture closing the mucosa to the mucosa?
Yeah. So all the vets that are watching this, for the next week, I want you to practice backhand suturing, so suturing away from you. It's a good skill to practice when you don't need it, because then when you do need it, you'll have that skill. So we did the bladder was huge and rock hard, so we did a cystocentesis prior to taking it to surgery. So that's definitely a good idea.
And he also asked, do you prefer continuous or interrupted suture pattern?
So definitely continuous. I do continuous in almost everything. I think there's a lot of need to do interrupted sutures for most things. That's something that we used to do a lot more of. So I'm just converting to a little intradermal pattern to close the residual defect. We're going to have a much bigger defect in a minute. I'm going to take his penis off.
And you do this first so you're confident that...
So I've done the urethrostomy first, mostly just to relieve the bladder obstruction. If it's for cancer, yeah, anyway. I do this commonly for like a penile mast cell tumor, where my objective is to get rid of the cancer, and I want to make sure that, well, but for one thing, I'm able to usually pass a urinary catheter, so I'm not worried about, relieving the obstruction. So in that case, I will do the penile amputation first. That's
They're very romantic, I put them.
that's lovely and a little bit weird. I had a vet from Washington State email me and tell me that she and her granddaughter, 5-year-old granddaughter, watch the videos all the time. It was actually a really sweet email where the granddaughter makes her stop the video when she has to go to the bathroom.
Surgeon in the making.
Yeah.
I told you my proud mum moment. Was going through a fracture repair, and Emily said, "Are you going to put a plate on it?"
Excellent. And
I
she's
was like, "Yes."
and she how old is she?
3. Just.
That's great.
And she said, "I'm going to put a 3-5 locking in it."
It's a tiny poodle.
And she would have been punished.
Go and write some lines.
3 journals by midnight.
Yeah. She would have learned that in rounds already. That Sarah has with her every night before she can go to bed. Okay, we're doing rounds today, Emily.
She does put on adults in hospital.
Cat's partner when they're in the dog park, like when we're in the park, you'll just see a breed and just go,
Oh.
and Labrador, and he'll be like, hip dysplasia.
Spider.
So we might be getting a little bit light. Thank you. So that's the bulbourethral gland down here. Is that bulbourethral gland or bulbospongiosis? Yeah. Just give it a minute. Go to number 4, Gail, please. Thanks.
If this penis wasn't so grossly abnormal, would you just do the urethrostomy and not do penile amputation?
Correct. Yeah. So Sarah's asking is if this dog was did not have a necrotic penis, would we just do the scrotal urethrostomy and leave the penis intact? And that is exactly right. Can I get some OPDS, please? So now what I'm going to do is get a right angle forcip, and we're going to do some ligatures around the base of the penis. And I think these vessels are thrombosed here. Okay, so let's get a So I'm putting a encircling ligature around the penis here, almost as a tourniquet.
Is there a distance, Charles, you want to be from your urethrostomy, or you have
Not
to just-
really. I'll just cut that. Thank you. There's not a specific distance, just leaving Like if it's for cancer, then obviously you need to,
Come as far as you need to.
yeah, get a margin, but. So now I'm just going to cut between. So I'm right down to the os penis here. So that's where the urethra was right there. Okay, and you can see the penis in cross-section, corpus cavernosum, and all those layers that I can't remember. So now we'll just elevate this.
And you typically aim to leave those vessels behind, Charles, or you're just leaving them because...
That's just how the dissection's going, so I will ligate those. So we've got some big vessels underneath here. Can we get that checked? Invalid instrument. Try to pull it out, go put it in another one. We'll have to get a new one, please. Does that say invalid instruments, right? No. So that's kind of cool.
Wow, that really comes out in a different way than I thought it would.
And eventually we're going to get to the point where we get to the, the preputial, the fornix of the...
Wow.
It's a
Like
little unsettling.
Hey?
It's a little unsettling.
It's like skinning a rabbit.
Yeah. I remember doing that in high school. It was pretty fun.
I think we went to very different high schools.
Look.
Remember my friend commenting when we did a chicken wing dissection, and I was like, thinking medical is helpful.
It's like chicken wing.
All right, so now what we're going to have to do here is amputate a portion of the prepuce. So just go right through here with a blade.
And is that for cosmetic reasons or just because you need to take out that opening?
We need to take out the opening. Can you untangle my...
And what do you use to have so little bleeding?
skill?
Really handed him that one, didn't you?
Yeah.
I'm just reading the comments.
So I use a lot of electric cautery and ligature and that kind of thing. And also just taking my time because I do want a bloodless surgery. And so it is a little bit of technique, knowing how to dissect things without cutting the vessels right underneath where you're dissecting. And that's something that just comes with experience. And again, a desire to do bloodless surgery. So that is one of my objectives. Hemostasis, so Halstead's principles. So ligature is invaluable, but you can't, be totally dependent on it. We may have to trim some of this skin out because we're leaving, a lot of skin with the dog.
I did notice that Sean was very unsure about how to grab that.
Alright, so next step is to get some larger gelpies in here. So we are doing a cystotomy because there are bladder stones. And there's also some concern that there was some free fluid in the abdomen, so we're going to check for leakage of the bladder as well. So now this is just a midline caudal abdominal exploratory. See where the pubis is right there. So yeah, I actually do make it one of my objectives, and I mentioned that, to have a virtually bloodless surgery. And I know a lot of other specialists don't have that as an objective, and that's fine. But I feel like it's important. I think I can see better by spending time on hemostasis, not to mention lack of blood loss. So now we're to midline linea. Remember that the linea gets very thin caudally. And there is a little bit of free fluid in here, not like a huge amount. Alright, so our bladder, luckily, does not look bad at all. So I was really worried that we were going to get in here and it was going to be black. All right, so let's get some 2OPDS. Yep.
If you do open it and the bladder, the majority of it is black,
Yeah.
what are your options?
If the I mean, one thing, like it's sometimes hard to differentiate from between a necrotic bladder and a just a very bruised, congested bladder. So one thing that I would definitely do before I just called the owner and decided to come to the end of the road is that I would, after relieving the obstruction, I would give it some time. So I would give it 10 or 15 minutes to see if things improved. Certainly, like with the stomach, when you've got a GDV, often you'll get in there and they just look terrible, and then you relieve the compression and give it a few minutes, and you'll see that it actually starts to turn pink again. All right, so I'll just switch. Can I get back to my 15 blade, if I've got one? Just see if I can position this a little bit better. So, and we used to think that you had, can you retract that quite forcefully up there? We used to think that you had to make cystotomy incisions on the ventral aspect of the bladder, but that's been shown not to be the case. And the concern was that we were trying to avoid adhesions to the ventral body wall, but that is actually not an issue. It's a big prostate here. I wonder when this dog was neutered.
He said it was quite a while ago, but
Okay.
I thought it was a bit big for the ultrasound as well.
Yeah. Do you have an idea of how many stones are in the bladder? Was there a
I
lot?
think it was like one big one and two or three small ones.
Okay.
You will
So big blood clot in there. So there's one big bladder stone there. Okay, suction right down in the trigone.
There's four small ones and one big one.
Okay, we passed one. So our critical care vet, Elvira, said that there was one big stone and then four small ones, and I cannot find the other one. So what we'll do now is, where's the urinary catheter? Here it is. So let's get some saline, and we'll flush from both directions. Yeah, let's get a new. Just get a new syringe. Yeah, 20 ml syringe. What we'll do is we'll go down from the urethrostomy in a cranial or proximal direction. And just so we've got the catheter coming out there. I can't feel any stones. But we'll, so now I'm flushing quite forcefully from the urethrostomy. Got one? Okay. Try again. We'll come back out a little bit further. So we're, what, 15 centimeters in. Just watch your head, Sarah.
I'm sorry.
Ready? Can I please get some 3O PDS? Alright, so I'm pretty happy that's clear. Now I'll go in the other direction. Flush out there and make sure no stones come out through the urethrostomy. Got it? All right, so I'm pretty happy we've gotten them all. So we've got 1, 2. Any more? We had one come out before. The other nice thing is that
We went out.
yeah, so that it's just right there. All right, so let's release.
Flossing procedure.
Not sure that was the best idea of me using the Gelpy in the bladder. All right, so where is our suture material? You can close the urinary bladder in 1 or 2 layers. Can you suction down there? I tend to do it in 2 if I can. Actually, you know what? I'm going to see where that little tear that I did with the Gelpy is.
And that black stuff, that's just blood clot.
Yeah.
Someone asked, is there any way to fix the ureter if it has been cut by mistake?
Ureter, yeah, you can reimplant the ureter in the abdominal wall, in the bladder wall. And that's something that we do routinely with ectopic ureters, is just reimplant them. So cutting a ureter is not ideal, but it certainly is not catastrophic if you know how to manage it.
Do you do anything different between ectopic ureters in cats versus dogs?
So question is, do we do anything different for ectopic ureters in cats than we do in dogs? The big one is that if it certainly, if you can't get a scope down the urethra, then you can't do the transurethral repair, so you'd have to do an open.
The cat's more commonly extramural.
I don't know the answer to that. Ewan? Ewan just asked if cats are more commonly extramural, and I don't know the answer to that.
Sean was hiding them.
Can you retract on that for me, please, Sean? And when I'm closing in 2 layers, I just want to make sure that I'm getting the layer that I think I am, which is the mucosa. So I'm getting mucosa and submucosa. Uh,
if it remains necrotic?
So, with necrotic bladder, and don't know if I've ever seen it or if I've seen it once. Obviously, if the bladder is truly necrotic, you're in big trouble. But I would not commit to, accepting a necrotic bladder without giving it some time after resolution of the obstruction, because often a really nasty bruised bladder will really improve after, with a few minutes of relieving the obstruction. If it is truly necrotic, like you can try doing things like implanting the ureters into the ileum or the colon or something like that, but I certainly have never done that, and I can't say that I'd really recommend it. When you review the results of those procedures in the literature, they're usually pretty poor outcome, with a lot of electrolyte abnormalities and ascending urinary tract infections and that kind of thing. I feel like we probably ought to have a Foley in this dog for about 4 days, just because of the stretching of the bladder, so it may become an atonic bladder, and I'm not totally happy with the integrity of the wall. So I think that would be the safer thing to do.
Like an 8 French or?
The biggest one you can get in there. So we could use that one. So I'm going to use a Lampert suture pattern here.
Like, what kind of pattern?
What do you do? Like an inverting pattern?
Yeah, so this is an inverting Lampert pattern.
Do you normally do that, or is it because you worry about the integrity of the wall?
A little bit worried about the integrity of the wall, and this is a big dog with a big bladder, and so I'm not worried about compromising the luminal integrity.
You'd removed a mass, or you're worried about the lumen size, would you just do simple continuous?
Yep. And you can do it in just one layer.
And do you have to bury the knots or?
Now, you don't want knots on the inside of the lumen,
Yeah.
but on the outside it's fine. You don't have, yeah.
Because you don't want them full initis in the lumen.
Because if you don't go through food thickness, then you technically don't.
If you,
If you don't do food thickness,
Yeah.
then when you bury, you would bury it at the lumen.
correct, yeah. All right, so are we pretty happy with how that looks? It's a bit lanky. I don't think that's gonna. All right, so we'll release our or stay suture. Now you know what I'm going to do is I'm going to squirt some saline into the bladder, just make sure that it's not overtly leaking. So I normally don't leak test, but since the bladder is a higher pressure system than the intestine, so that's pretty good so far. Yeah. Do we have the kidney dish still? No.
No.
That's all good. So I'm just draining the bladder again. Can you get some warm saline, please? Yeah, so we'll leave that in for 4 days.
I don't think that's the following.
Yeah, so we'll put in a bullet in, yeah.
Do you need a stomach in addition?
No, we're all good. Thank you. All right, so we'll just do a lavage of the abdomen and then just do a routine closure of the abdominal wall. And that's pretty much it. So just come over and make sure there aren't any. So the question is, so do you recommend waiting 10 minutes after we resolve the obstruction to see what the bladder wall looks like? That is correct. Urinary catheter, generally you can resolve most leakage in about 4 days anywhere in the urinary tract, so 4 days to a week. Because we've done a leak test and stuff, and we're pretty happy that this is not going to leak post-operatively. I would leave it in for about 4 days. If there's any question, you can leave it in for 7 days. And the other thing that you can do is to inflate it with contrast and then take an X-ray. All right, so we'll go ahead and wrap it up now. Thank you very much for watching. I think that was a fun surgery to do, and certainly something that you're going to see in primary care practice. So maybe a few little hints to help you manage those types of things. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. And we will see you again soon. Hopefully I'll have some stuff to live stream tomorrow.